Got it.
Thank you. All righty. Welcome, everybody. So we'll get started here in just a minute. Tonight we have Dr. Stephen Capobianco. He's going by Capo, so I'll let him introduce himself. But this is all kind of about the idea behind this is kind of spurred on from our recent rep retreat and kind of answering the why behind we use, like the reasons why we use a lot of stuff that we do in the treatment room. So RockTape is a awesome friend of Rehab to Performance, and they do a lot for us. And if you are a club looking for some help, they're a great group to reach out to. Got to thank MJ as well, because she's been a lifesaver in a lot of situations for us. So without further ado, I'll let Capo take over and go through it.
Great. Thanks, Sean. I honestly, when I was asked this, it's an immediate yes. Anytime I get the opportunity to speak to a student group, in particular a rehab student group, I'm all about it. I've been, which is amazing to me that I'm saying this, in practice for 20 years, which you guys can all nod your heads and say, well, that doesn't sound like much, but it's amazing what's changed over the 20 years. And that's what I'm going to basically attempt to talk to you guys about, attempting to take a breath every once in a while. How much time do I have, by the way?
Usually these things run for like 60 to 90 minutes. So whatever you got.
Okay. All right. Great. And you know, what I want to deliver was exactly what Sean primed me to focus on, which was just over those 20 years and what I've learned over the last 12 years of starting RockTape and delivering our education. I want to share the evolution of thinking. And so I want to preface the conversation that I'll be having is going to be focused around movement, which I think resonates with your message. Most of my education outside of my formal chiropractic degree revolves around rehab and helping people move in a more effective and efficient way, which I'll talk about in a second. I definitely do have a strength and conditioning background, so there's a lens of that. So you could see what types of glasses I'm looking at when I'm looking at someone on my table or looking at someone in a performance realm. So that's kind of like how I'm going to talk about this discussion. I do want to preface the idea, even though I'm wearing RockTape, it's just the only clothing that I actually have. So just excuse me for a lack of wardrobe. I just wear RockTape. I started the company, but everything that I'm delivering today, even though you'll see RockTape imagery, it needs to be understood that you could use the concepts that I'll be talking about with any like type of product or tool. So this is not intended to be a sales pitch, even though it probably looks like one. The goal that I had for tonight was to talk about systems, not techniques, which is a core concept that we teach within our curriculum. I don't believe in techniques. I believe that techniques kind of present themselves depending on the individual that you're working with and the environment. We'll talk about what I believe that we're actually treating, which diverges somewhat significantly from what I was taught formally. All of this is going to be based around this idea of the predictive embodiment approach. It's a mouthful, but it really makes sense, and I hope it makes sense to you by the time I'm done, which helps to titrate or alter the dosages that I'll be using. You know, how much pressure do I want to add? You know, how quick, how long? You know, those are questions we should all be asking. And I think those are the things that you were looking for in respect to the why behind the what. Sean, I'm hoping I could deliver that using this predictive embodiment approach. And then at the end, I'll just kind of deliver to you guys if I have time. Again, I don't even know if I can get through all of this, but I'll talk about this idea of stacking, how we can start to layer or stack different interventions together to create a more robust outcome. So as I said earlier, you know, everything that I talk about is focused on helping someone move more effectively and efficiently. And why do I think that this is more important than understanding how to get someone out of pain alone? And you could argue with me, and I think it would be a great discussion, but I believe that people come to see us as clinicians, not necessarily because of pain. They're coming to us because pain is limiting them from moving in a meaningful way. So movement is the aspirational goal. And we know that we move around pain. So pain could be identified as the key target, but the target really should be what motivates that individual to follow through. Because if you can't improve their movement quality, effectiveness, and efficiency, good luck getting them to actually change some type of behavior that gives them long-standing change. So those are the things that I really want you to start thinking about, is that one, pain is much more than just nociception, which we'll discuss, and pain is a component of the problem, but not the problem. In my opinion, movement should be the goal. And ultimately, I'm going to be hopefully changing some of your belief patterns, because I believe that most of us have no problem arguing. Just take social media as a great example, arguing with anyone that believes differently than us. But I think the real problem is that we're not challenging the current status quo, those that agree with us. Because if we're not challenging each other, even what I'm going to talk to you about tonight, challenging the current concepts of how we use a tool or a strip of tape or our hands even, then how do we actually evolve or grow? So I really want you to challenge me, and some of you have in the past, and I appreciate it. And I take it seriously. And I'm going to share a video, and you, Sean, give me a thumbs up if you guys can hear the sound. Once I saw this, and this is old, this is probably predating me, which is definitely old. I just laughed, and it really kind of gave me a different lens of thinking when it comes to challenging belief systems. So tell me if you can hear the sound.
The Ash experiment is one of psychology's oldest and most popular pieces of research. A volunteer is told that he's taking part in a visual perception test. What he doesn't know is that the other participants are actors, and he's the only person taking part in the real test, which is actually about group conformity.
Please begin. The experiment you will be taking part in today involves the perception of line length. Your task will be simply to look at the line here on the left and indicate which of the 3 lines on the right is equal to it in length. So, for example, if you...
The actors have been told to match the wrong lines. The volunteer will be monitored to see if he gives the correct answer or if he goes along with the opinion of the group and gives the wrong answer. In the first test, the correct answer is 2.
1. 1. 1. Two.
1. Once again, the correct answer is 2.
3. 3. 3. 3.
3.
The Ash experiment has been repeated many times, and the results have been supported again and again. We will conform to the group. Again, we're very social creatures. We're very much aware of what the people around us think. We want to be liked. We don't want to be seen to rock the boat, so we will go along with the group. Even if we don't believe what people are saying, we'll still go along.
1. 1. 1.
Group dynamics is one of the most powerful forces in human psychology.
And we'll get into further on the group dynamics, but group dynamics matter. And you guys all know this, you live it on a daily basis. I just thought that experiment, has anyone ever heard of that experiment before? It has been replicated many, many times. Obviously, I probably found one of the earliest, just looking at the hairdos. But the point was, I want us to challenge all of our belief systems, and that starts off with your formal education. And my formal education, I'll speak for myself, was basically focusing on fixing structural, things. We were mechanics. Push on this bone in this specific vector to have this specific effect. And I felt that I had a great education, mind you, but I'm still somewhat amazed of how long I conformed to the group. And what I'm going to ask you guys to start thinking about is probably not changing the philosophy, but reframing our philosophy, and more so focusing on how we interact with our patients, more so than what we actually think we're fixing or not. And that's going to be the basis of what I'll be discussing today. And a lot of this is based around what we're learning about chronic or persistent pain. And you guys will be inundated with it once you all get into practice, because as the population's getting older, these numbers are only escalating. And this is a great paper for you to reference. It's a 2015 paper from Crawford. I'll provide these slide notes for you guys if you guys want to reference any of this information. But it was really well done, and it really talks about how the brain meets the body. And this is going to be a component of this embodiment idea that I want to present to you guys tonight as it relates to managing chronic pain and managing movement as a whole. And we know that we're drastically missing the mark when it comes to managing chronic or persistent pain. And quite often we're coming up with different diagnoses. And the one that's somewhat problematic, in my opinion, is, and it's a significant portion of people that are seeing their general practitioners, up to 2/3 of the population that are coming in with chronic pain are being diagnosed with something that's called medically unexplained symptoms. It's slowly starting to transition to somatic symptom disorder, which I think is a better diagnosis, but MUS is just saying that we don't understand why this person is experiencing what they're experiencing. And other things that fall under that umbrella are those chronic functional syndromes, fibromyalgia, IBS, and CRPS as well, and others as well. We know it's a significant problem worldwide, low back being the #1 burden when it comes to chronic pain sites of the body. And we know that it's only increasing as the population increases in age. And we know that we're inadequate. As a general rule, we're not solving the problem. The chronic burden of disease globally is not improving. It's only getting worse. So with all the technology and information that we've gathered as mechanics is not making a dent on this type of problem. So we have to start thinking about changing our viewpoint and really getting away from this idea that one size fits all, that, pushing on a bone, using a tool or a strip of tape on a specific area of the body is going to fix everything. It's just not the case. So we have to have a wider swath of addressing the individuals that we work with, similar to how we would address someone's signature. And I'm bringing this up because you could look at a signature and you could recognize it, but replicating it is very difficult. And the same thing is true when it comes to human movement. You could look at someone moving, and without having any significant training, you could look at two people moving and you'd say that one movement just looks more seamless, more natural, less cumbersome. And those are signatures that we have within our body. And so I want to take this idea of understanding that there's some variability when it comes to movement, just like there is some variability in how we sign our signatures. They're recognizable still, but there should be some variability, and accepting the fact that we are variable individuals, variable human beings. It really allows us to kind of expand our aperture when it comes to looking at human movement and looking at how we address human movement. And this is a great exercise that I like having people go through. And I'm not asking you guys all to do this unless you want to, but this is an exercise that I used to do with my athletes. And I would just basically have them start with a face down position like this individual is here. And as Dan John would say, and Dan John, if anyone follows him, he's just very simple in his instructions, and he says, get back up. And so he basically wants to see how different people would actually do the act of, from a face down position, how did they get back up? Laying on your right side versus your left side, how do you get back up? From a high plank position, how do you get back up? and then from your back. And then what he does to be able to start to challenge people's capacity to get up in a specific way, he starts to put certain barriers to be able to make it more or less challenging. The example would be putting this person's right hand behind their head, for example, and then asking them to get back up. It is going to be different than having both hands behind the head. And again, you can practice this and you can do this with your own friends and colleagues. It's a fun drinking game if you want to try it. Just make sure you guys are all safe when you do so. But the point is that you'll quickly identify how everyone has a different strategy to be able to accomplish the same task, which is ultimately just getting back up. And so why I like this is, and why Dan John would agree with me, is that there shouldn't be a stereotype. Now, that stereotype can be altered if we're talking about max lifts. There are certain biomechanical advantages of having your body in a specific way to lift a specific weight, but just to move naturally through space, we should be very careful of stereotyping how someone moves, because what we're learning very quickly is that there isn't a movement ideal. And when you start putting a movement ideal on things like squatting, which I'll show you examples of, then we start leading into almost like body shaming, the equivalent to body shaming, saying if you don't look like the expectation of the group, then we're going to shame you. Well, the same thing can happen if we start putting aberrant ideals on human movement when we know it needs to be more variable to move through space. That we could start applying movement shaming, which people eventually will just avoid movement altogether, which isn't a good thing either. So I'm on this soapbox lately to be able to kind of identify that I think we're focusing too much attention on biomechanics when the system is a lot more variable and a lot more complex. And the examples you see in most literature, you'll see, examples of this, the how to perform the perfect squat. And if you don't look like this, and I don't look like this when I squat, and I squat relatively heavy, then am I not moving in the perfect fashion? Am I going to now alter my personal biomechanics to fit the ideal that someone has identified without very much research? I'm sure you guys have seen images like this. Images, I don't necessarily know exactly what is wrong with the big X here with this individual, but some of you might have an opinion. Say, well, those toes look like they're over the knees are over the toes, and the spine might be too erect. And we could all have our opinion, but do we really know that that is not the effective way of moving for this individual for this specific task? So I can show you again, more and more examples, but the point is, I think that we get handcuffed by this structuralist approach because we're always taught and pushed towards moving something biomechanically, even though most of the evidence is not necessarily supporting the idea that we can predict potential injury from biomechanical faults alone. So I think that there needs to be more variation in our approach. So if I do have this stance, I hope that a question you guys would have is that, well, what do you do then? Like, how do you interact with someone? And I think it all starts off by having a definition. And I'm going to share with you a definition that I've been working on for 20 plus years. This is while I was a trainer, mind you, but it's now evolved to this stage here. And I'll tease this out in more detail. But what we're talking about when it comes to movement fluency, if movement is the goal again, which I'm claiming that it is, that we need to be able to assume the necessary shapes. You could add in postures, positions, poses, whatever you want in that place, but I use the term shape to allow the body to fulfill a specific task: squat, lunge, deadlift, jog, pick up a kid, whatever it may be, in the most efficient and effective manner in any environment. That's what I would consider fluency in movement. So let's just kind of break this down a little bit more. Shape, like I said, these are all different shapes that your body should be able to assume. What's effective would be, can you get it done? Do you have the necessary range of motion, pliability, extensibility, whatever term you want, but do you have the necessary motion of the body parts that you do have depending if you're able or not. Do you have the effective mechanics in the body to assume the shape? And then the second part, which is, in my opinion, much more important, would be efficiency. So effectiveness, do you have the shape prerequisites, yes or no, to accomplish that task? Efficiency is a little bit more complex, and this is asking the question, how well can you do it? So this now starts to ask the question, is it a defect that you can't assume that shape, or is it a defensive posture, or is it a defensive shape? And this all comes down to the brain, which I'll be focusing my attention on tonight, and the brain's assessment of threat. If your brain thinks that this movement, whatever these movements are, is a threat to its safety, to its longevity, it will change something to protect itself. So in my definition of efficiency, I believe that efficiency is a component of neurological threat assessment, how the brain is evaluating threat. So what could be some of the signs that we would see in a patient or client that is demonstrating signs of threat, signs of lack of efficiency? And so these are really signs of lack of confidence. The example would be this individual crossing this bridge. You know, how confident is this individual going to continue on the path when they can't necessarily see what the next step is going to look like? So you would generally see someone behave differently when they don't feel as confident in their next step, their next movement, compared to someone that does. So uncertainty definitely decreases your confidence, which will have an effect on your ability to move. And this really follows the competence relationship, which really states that if you're not confident in your ability to move or your next step, then your competence in that next step is going to be compromised. And so I believe, and this is where the research is really leaning towards, is that your ability to understand where your body is in space is critically important. Your ability to have a clear picture of your body in space is critically important to improve your confidence in movement. So this isn't the idea of, if I was driving around in a city that I don't recognize and my GPS goes haywire and I can't necessarily know what street I'm on, what is my confidence to be able to reach a specific, destination? Probably going to decrease. Maybe my threat goes up because I'm driving through a neighborhood that could be deemed a risk. So having a clear picture, a clear map, is critically important to improve our brain's capacity to be able to move. And this is just another example.
Trying out Rocco's winter boots.
If any of you have dogs, I have dogs. I have a horse. Actually, a horse is a great example. When we don't shoe it correctly, the horse immediately changes its behavior, significantly changes its behavior. But dogs, my dog, I live in Austin, Texas, so it's unlikely I'm be putting my dogs in booties. But when you do, and the dogs aren't used to it, again, you're immediately changing their map, their sense of where their paws are in space, and you see immediate changes in their behavior. So we really should start looking at these inefficiency indicators, because as you become better at identifying inefficiency in someone, you can start to tackle that versus just tackling what you might think is a biomechanical issue only. We need to start thinking about the threat indicators or inefficiency indicators. And the best way that I can explain this, and I'm hoping the majority of people on this call, I had the same conversation with my European team, and I've just typical, not paying attention, that I just thought everyone knew what a Heisman was, and not everyone does. Duh. And so the Heisman is just my explanation, and it was a patient that initially presented this, and one of our instructors has been really promoting it, is that this is what a patient will basically tell you when they're not confident, when they're under threat. They'll basically do what the Heisman's doing, is literally pushing away the threat. And they're going to give you indications of what that looks like. And these are all common signs of fear, threat, inefficiencies, pupil dilation, breath holding, grunting, clenching of your fist or your toes, just inadequate perspiration for the task that you're putting them under. Skin blanching is another one that I've been noticing more now that I'm recognizing it. Increased heart rate, just by thinking about a specific movement. So you might say, we're going to be doing X movement that you already know is going to be, leaning into threat, and start to evaluate how their autonomic nervous system actually addresses that threat, that potential threat, mind you. So these are all things that I truly believe, and this is something that I've just gained over experience. But once you're more aware of these early on, you refine this muscle, your ability to identify these earlier, so then you can address this component of the movement dynamic, which I can assure you is going to have an effect on pain as well, by improving their confidence. And so again, these are just all examples of poor body maps will kind of demonstrate with these types of signs. Usually it's associated with a lack of midline control. All the DNSers out there, which I know a lot of you are, and I am as well, that I truly believe that someone that's lacking in body awareness, which I'm sure you guys have all done if you've been working with each other or any of your clients, that you're applying DNS protocols and having that individual figure out where their pelvis is in space in relationship to their thorax. Many of them have no clue, right? So that their maps are compromised, and now you're going to put them into, a 6-month position. You're going to see these signs immediately, because their nervous system is telling you they're not clear, they're not confident, and that they're going to have some kind of response, and the response are going to be these types of autonomic Heismans. So I'm setting the stage for what this slide is showing, and some of you might be even better versed in this than I am, but I want to share with you how this has altered how I use a myofascial cup, how I use a myofascial ball, a strip of tape. This has now given me another target, a target that I feel is better supported by the evidence, is definitely taking into account chronic symptomology and how we respond to chronic symptoms. Is this complex interplay within the central nervous system, the brain in particular. And so and you're going to see this a couple of times in different variations of the same image, but we need to understand that there is no pain center of the brain. There really isn't a sensory center of the brain, an emotional center of the brain, even though we know that there are regions of the brain that are highlighted during different responses from the body, but they all work in a complex and interactive way. So the ones that I want to highlight here are important as it relates to the mapping concept that I just brought up, is that if your maps are unclear, then it leads to a threat response. And the mapping centers that have been identified are kind of identified in these 3 different colors. The blue are going to be the centers that are mostly recognized to be involved with sensory discrimination. The where on the body are we talking about? So we talk about the primary and the secondary somatosensory cortices. The second one would be the affective or motivational aspects in the orange. The main centers that are been identified for the affective or motivational component of maps are going to be the insula and the anterior cingulate cortex. And then lastly would be the cognitive or the evaluative. And those are going to be in the lighter green outside of the thalamus. The lighter green would be the dorsolateral prefrontal cortex. By no means am I asking any of you guys to know these by heart. Some of you guys might already. But as you start diving into what the literature is saying as it relates to clarifying our movement maps, all of these regions, these centers should be considered. And the good thing is that we can actually feed all of these centers through inputs from the body. And that's how I really position. And if you want to kind of like a short form of this long lecture, a strip of tape to me is an input to the body. A myofascial ball is an input to the body. I'm not taping a muscle. I'm not releasing fascia. I'm not mobilizing, a joint. I'm providing input to the brain that the brain now applies into multiple different maps. And the ones that we're going to focus on are these three in particular, to be able to improve or decrease the threat the brain has for a future task, a future movement. So that's kind of I'm setting the stage, and I'll be adding to this as we move forward. So just to kind of add more, and as it relates to pain, these same three centers are also involved. So there's a sensory dimension to pain, there's an emotional dimension to pain, and a cognitive dimension to pain. How, where it hurts and how much, how unpleasant is it, how unpleasant is the experience, and how does this feed a specific emotion? And then what does this mean? Like, how does this going to affect my future from what I've learned in the past? And so the way that I explain it here is, to my patients, is that if you're having a back, symptom, you're having back pain, there are multiple conversations happening in multiple different regions of the brain. There's the ouch, that hurts, and the hurts could say it's my left side of my back. It could be that I do recall this from the past, and that recall can actually either inflate or diminish my symptoms because the previous experience that resembled this went away within hours, or it stayed for 6 months that had me miss my my marathon that I trained a year for. So it could definitely alter the emotional component of the experience, the cognitive component. It changes our emotions. I get sad when I'm experiencing these types of symptoms. I start thinking about what the future may look like, and I'll never run again. That can also inflate my symptoms. And then there's usually garbled information that doesn't mean anything really. So like the point is that it's a complex interplay of multiple different centers, but understanding that we could potentially identify specific centers that we can access and change that conversation. The term that you'll hear in this embodiment approach is reappraisal or reconceptualization, because our maps are clarified and we feed those maps with information that we're not really paying attention to. But if we change the input and add some intention behind it, I can assure you're going to start to reorganize these maps and these regions of the brain for the better. And that's what I'm going to present to you guys today. So the target to me is not the meat. It's not the tissue. This is a slide that I've been using for quite some time. It's critically important to understand there's a person attached to the meat, right? And that person is coming to us with different sensory and motor, environments. They're not a cookie cutter machine that we say, well, I know why you're in pain. You squat like shit. And you start organizing their maps by the things you say out of your mouth, the things you imply, your body language can actually affect their sensory and motor mapping. And then you add other layers of previous experience, history, emotions, cognitions, understanding of movement and pain. All of that is going to influence the experience. So I truly believe it's a person and their brain attached to the tissues that we think we're intervening with. So that is the kind of the ultimate goal. Why did I add the brain? Well, the brain's number one job is to keep us alive. It's always throwing a safety net over some type of threat, regardless if it's real or presumed, right? So we can't expect that we know what the brain is interpreting when it comes to a specific threat, because it's fed by so many different pieces of information. So it's always trying to predict the future. It's doing so through multiple calculations on a millisecond basis. And so we really have to understand that this, in my opinion, and I should start with that, is that I believe that this is the goal, is threat mitigation, to be able to alter the alarm system, which has been shown, and this is again not opinion, by reducing threat, improving confidence, we can reduce pain perception, we can improve mobility or the effectiveness of our shapes, and we can improve motor control. So those are the things that we're looking for, but I believe that it's about threat mitigation. So if I can kind of change the the pictures that I would be giving. And I think it's critically important that we're able to convey this information to our patients, right? So if I'm going to be talking about the dorsolateral prefrontal cortex, which I don't even know everything about, let alone, a neuroscientist like my wife, we need to be able to figure out how to communicate this to our patient. What am I trying to achieve with you? And I like to use pop culture quite often. If any of you watched the Inside Out, which is a great movie, by the way, not just for kids, there's multiple characters that this person is interacting with within their own brain. And I believe that there are multiple characters or maps, regions. I'm using all those terms interchangeably. These are three maps that I believe, as chiropractors, as movement therapists, that we can interact with, we can change the conversation with, to be able to influence pain, movement, pain, mobility, motor control, movement as a whole. So the three that we're going to focus on are exteroception, proprioception, which most of us kind of lump in as everything, which it's not, and then interoception, which is a critical component that I think a lot of us have missed, at least in my generation. So these are the three areas, similar to the areas that I just referred to you, that we can actually influence from the outside in, and which we know that by improving our proprioception, our exteroception, and interoception, I'll define each of these in more detail so you can know where I'm coming from. The brain's ability to predict the future is going to be improved. So that in itself, clarifying these maps can actually decrease the threat overall. And the reason I chose those three maps, because there are others, and I want to specify there are multiple other maps that we could potentially interact with, but these are three that I feel that we could effectively interact with our hands and tools, is that the majority of those that are experiencing pain have dysfunction in those three in particular, a lack of embodiment, so disembodiment, so a lack of clarity in their exteroceptive map, their outer map, where my appendages are in relationship to the environment I'm in, a lack of proprioceptive or movement map, knowing where my body is through movement, and then lack of interoception would be a lack of sense of what's happening inside my body. Most people would think interoception is typically, do I have to go to the bathroom or not? It's much more complex than just looking at, voiding your bladder. So that we're going to talk about these three maps, because this has changed how I apply a strip of tape now, where and why and how I would apply a cup on someone, focusing on clarifying these three specific maps: the extero or outer map, the proprio or the movement map, and then the intero or the inner map. This is a deep slide, but it is going to set us up for what I'm going to talk about for the rest of this. The references at the bottom, you probably can't read it, but I'll send you these slide notes. And this is actually missing the proprioceptive component of it, but I think it's telling a story that is more complete than most when it comes to chronic pain in particular, but we can insert other forms of pain in here, from acute to subacute to chronic, because it all comes down to scale, right? And so the outer circle, let's look on the left side of the screen, if you will. So we're talking with someone that's experiencing chronic pain. Generally, someone that's experiencing chronic pain, and we know this by the questionnaires that individuals with chronic pain fill out, consistently have higher pain-related fear and anxiety symptoms. So their symptoms, and we don't know chicken or egg, but we know that chronic pain sufferers have higher levels of anxiety and fear. So the threat indicator has gone up. Their autonomic Heisman is literally pushing away everything that's going to be elevating their symptoms. The typical response or behavioral response to fear and anxiety of a specific movement that causes pain is avoidance. So avoidance leads to changes in your exteroceptive map. If I'm not using it, I'm going to lose it. So it's very clear, and they've done this with macaque monkeys, where they've stitched two fingers together and they evaluated the somatosensory representation of their hand. Within minutes, we're seeing changes of the representation of the hand of being 5 digits to 4. And then we can cut those stitches. And then as long as the animal is articulating with the environment, within a very short amount of time, surprisingly short, we're seeing an improvement, a reclarification of that map from 4 to 5 fingers. So movement is critically important to our exteroceptive map clarity. And so when we avoid movement, our outer map becomes smudged, becomes diminished, leads to decreased in agility. Agility is not referencing your ability to go through a speed ladder. It means that your ability to respond to a stimuli is going to be compromised. So now you're adding even more threat, saying, I don't know where my extremities are in space. I'm using that as an example. And if I'm presented with a stimulus and I can't respond quick enough, then it leads to decreased self-confidence. Again, going back to that confidence indicator that I talked about earlier. And then leads to decreased functional isolation, more depression, and it just feeds itself. The second part of this is newly understood, is not only is it affecting our outer map, it's affecting our self-regulation of our inner map, our ability to assess what's happening inside. And this is critically important for us to really think about, is that when you're in chronic pain, it leads to altered interoceptive awareness, an altered sense of what you're actually feeling inside. This is so important. It leads to dysregulation. The dysregulation I'm referring to is that if I'm feeling pain, the sensation of pain, that might override, because of the threat associated with it, an internal sense of the sense of fullness, the sense of my breathing, the sense of my heart rate. These are senses that actually can be altered. And when you dysregulate your ability to sense what's happening inside, the nervous system goes into super protective mode. So we have to make sure that we're keeping all of our maps. The 3 that we're going to reference are the outer, inner, and the proprioceptive map that is missing on this graph. But it's so important. So how do we interact with it? I'm going to kind of shift to the right side of the screen. And what the evidence is telling us, and this is Valenzuela's group and others, that are saying that the integration of some type of sensory motor integration, so some type of stimulus, it could be our hands, it could be a strip of tape, a tool, a blood pressure cuff, like there's so many things that we can do to create an input to the body. But the key here, the caveat is, you're going to combine that with non-judgmental connection. What the hell does that mean? It means that you're going to be combining an input with the exercise of curiosity is the best way that I can put this in. You're going to ask the individual, the patient, and again, I'm asking you to kind of stretch your view of how the interaction between a doctor and a patient looks as a manual therapist, is that the evidence is starting to say that we now interact with them manually, sensory motor integration, but now we're bringing them into the conversation, bringing them into the experience and asking them to convey curiosity. What are they feeling? Is it sharp, dull? Is it fast? Is it slow? Is it warm? Is it cool? Is there a color that you feel? And don't be surprised if people actually present a color that they're experiencing when you're doing a specific intervention with them. Does it really matter what they're feeling? No. The point is, if they're connecting to their body in a non-judgmental, so they're not saying, oh shit, that feels hot. Am I on fire? No. Is something bleeding? No. So the judgmental connection would be counterproductive. But your job is to guide them in a non-judgmental way. I'll show you ways that I've learned through experience and what the research is telling us, that there are ways of doing this in a productive way. And the cool thing is, by doing this, and I'm just showing examples of tools that we could use as the sensor motor integration, that we can improve self-regulation, we can improve our reaction to a stimulus, and I'll show you ways of doing that. We can improve our self-confidence, which leads to more competence, which leads to improvements in mood and functionality as a whole. This slide is jam-packed with a lot of information. And some of you probably scratching your head saying, you got to shut up now, which I will, and I'll ask if there's any questions. But all of this is based around the embodied predictive processing approach. And this is going to be, it's going to be gaining more traction. And the reason is because there's a movement going from how I was taught as a bone, as a spinal specialist pushing on a specific bone. And I'm not even joking. That's the information that I was given. And then moving all the way to the other end of the spectrum, which is just basic talk therapy. So you guys have been on social long enough. If you follow guys like Adam Meekins, a show of hands, anyone listen to Adam, a physiotherapist from the UK. He would say the left side of this spectrum is nonsense. There's no evidence to support any of these manual approaches actually have any effect. He believes that he's probably more of a centralist, meaning more movement and confidence in movement and clarity in movement will actually get you where you want, along with some understanding. So he probably leans more to the middle, to the one side. I probably would agree with him. But I actually pull manual therapy into my conversation. So I'm going to present to you this spectrum, or I guess this philosophy of approach that really is pulling from both ends of the spectrum. Is pulling from manual therapy tactics that we've all are being trained or have been trained, taking into account meaningful movement, and also taking into account the interpretation of the symptoms that someone's feeling through traditional talk therapy, of which we all do. We're always talking to our patients. So the embodied approach is going to be looking at clarifying these three maps, which I'm going to kind of give you some evidence now. I'll see if there's any questions at first, and then I'll get into more of the specifics of how some of these tools work. We're doing so by improving our predictive capacity, which has definitely been shown to empower people, to give them hope that they can actually move with less dysfunction, less pain, and improve their overall control of their own bodies. So I'm really talking about using the tools that we have access to, including our hands, in a guided approach to be able to clarify the three maps that I referenced earlier. This is not just me. If any of you are involved with the VA, of which I think you all should have at least a round through a VA facility to really look at the brunt of what chronic pain is actually having on individuals, at least in this country, are veterans. And the VA has recognized that traditional manual therapy is not the only answer. So they've evolved their approach, and it's called the whole health approach. And I want you to kind of just recognize, and I'll see if I don't know if I could do it effectively. I can't. But if you look at the center of this circle, it revolves around me, the individual, right? So you're taking the individual first, and look at the immediate adjacent, components of this whole approach is mindfulness, mindful awareness. And this is the part that I was talking about in respect to curiosity that I have to tell you is significantly important. By having the individual become more curious of what they're experiencing can actually de-escalate the threat. And so if organizations like the VA are taking a stance to now start talking about mindfulness as a component of pain management, we should all be considering it in more detail. And that's something that I strongly believe in now. So it's not only the brain, but it's the mind, how we connect the brain and the mind together with the body. And really, I think this will become more apparent to you as you guys get into practice. And some of you might be early in practice, and some of you might be students. I'm not exactly sure of the dynamics. But when you look at your daily schedule as a clinician, and you scroll down and you see that chronic pain patient or that individual that is not responding to care, that deflates your confidence as a practitioner. And it's really challenging to be able to continue to work with someone knowing that what you've been trained to do isn't really working. So not only is it improving the patient outcomes, it makes our profession more rewarding when we know that we have more tools in our toolkit outside of just the tools themselves. And that's why I started off this lecture with rule the tool, don't let the tool rule you. I could care less what tool you use. I want you to understand the why behind it. And I believe that the why is that we're interacting through inputs, sensor motor inputs, along with mindfulness to be able to create a robust change in the central nervous system. So I'll stop there and see if there's any questions. So then I just don't talk over you guys for an hour and a half. Usually I get crickets here, but I'm thinking you guys might step up. Who wants to say anything?
I've got a question, actually.
Mhm.
So
Shoot.
you were saying that encouraging more of the creativity, or excuse me, more of the curiosity in the patient, and asking them, hey, how does this feel? How can you encourage more curiosity outside of just that, either 15, 20-minute patient visit?
Yeah, so you mean extending the benefit outside of the office, is that right?
Yeah, absolutely.
Yeah, so these are just tactics that you will start to you have them experience and hone on the table or in your facility, depending on how you treat. And then you're going to extend this outside of the office. So the example we're talking about, and this is where Meekins and I would differ, saying something like this, a simple spiky ball, you can get in multiple different ways. If I felt that interacting with someone's foot, their plantar aspect of their foot, as I had them applying a mindful curiosity to the sensations that they're experiencing while I was doing the intervention, was giving them an amelioration, an improvement in their symptoms, an improvement in some marker that we assessed prior, then I'm going to have them extend that outside. So the exercise would be, I'm not just going to have you mash the tissue. I want you to replicate the dosage that I provided you, because I made you more aware of how deep. How deep is this? Well, and I will guide people, because then you'll get a lot of different interpretations saying, is that mild, moderate, or deep? Oh, that's moderate. Great. So I want you to think about that moderate pressure that I applied with my hand or a tool or whatever. And I want you to apply the same type of mindfulness, and then I will guide them on that, and which they experience on the table. So while I'm rolling the bottom of the foot, saying, okay, that's a moderate pressure. So we're starting to clarify that outer map, right? So, and I'll show you this in more detail later. So we're starting to clarify that outer map. What does that feel like? Is it fast or slow? And the answer doesn't matter. It's just they're thinking about it. Yeah, that feels kind of fast to me. Great. Moderate pressure, fast rate. Does that feel like it's getting warm or cool, or is there a change in temperature? You know what, doc? I'm feeling some warmth, and which I would expect if we're rubbing an area for a period of time. So now they're starting to think inside, I'm feeling some temperature change. Great. And so again, I'm not having them say, that feels warm. Oh shit, something's wrong. I'm saying, what does it feel like? And I guide them with some type of cueing words, cueing descriptors. So answering your question in a long form, I would have them extend that at their home, doing that same exercise. It's mindful manual meditation. That makes sense?
No, that was great. Thank you.
Okay, great. All right, so I'll relieve you guys and just continue on. Sean, if you need, give me a signal if I'm just overshooting. Now we're close. Gosh, we're almost an hour. I cannot believe that.
You're good.
So,
keep rolling.
But the point here's, I'm not getting to I've gotten to the meat. That what I just presented is the meat of this presentation, because if you guys lead with this identifying that these are different targets other than just quote unquote releasing a hamstring or manipulating a PI or an AS ileum, sure, you're doing something to the system, but you're providing an input. I'm just asking you to add a couple of different layers on top of that experience to get a more robust outcome. So this is coming from, and this is a great study for you guys, and it's more of a collection of research that are talking about when it comes to touch, and touch is extended not just with hands-on touch, but even using instrument, has a physical property and an emotional property. We should all recognize that having a physician put their hand on someone versus some creepy guy that just walked down the street and crawled through a window and put the hands on the same way is going to be interpreted differently by that individual, right? Emotionally and physically. But the component that I really want to highlight here is that there's an analgesic touch response that dosage-wise, there's an affective response, so I can titrate the experience to be able to stimulate that part of the brain that I talked about earlier, the affective motivational center. And then there's a type of touch that will preferentially stimulate the somatoperceptual zone. That's going to be the S1, S2 regions of the somatosensory cortex. So we have the ability through touch to preferentially communicate, talk to those specific centers. Some of those centers are interrelated to the 3 map regions that I talked about. So the reason I think this is important, this is how I'm going to communicate dosaging, to be able to, if you feel that through your assessment that someone their outer map seems pretty clear, how I assess outer map is 2-point discrimination. So a lot of you probably been trained with 2-point discrimination. Most of you are told that you're just looking at, neurological deficits along dermatomal patterns. I would want you to expand your aperture here and use it to be able to get a sense of someone's map. Forget about a dermatomal distribution unless there's a stark, obvious distribution that you should pay attention to. But if you're looking on someone that's got chronic shoulder pain, get a picture of how clearly do they know where their shoulder is in space. 2-point discrimination is a great objective tool to assess someone's outer map. So if you can identify that their outer map is compromised, going back to this slide here, I'm going to focus most of my attention on the somatoperceptual reorganization. I want to feed that map most. So it definitely gives you some guidance of which map do I need to tap into. So there's screening methods for outer maps. There's screening methods, which I think I have in this slide deck, that you can objectively measure your inner map clarity. It's called the Maya screen. And then the movement map, we all know this, right? Range of motion, movement, screening. There's multiple ways of screening movement. I'm sure all of you have your methods that you prefer, but you can measure these and then identify which one do I want to target. And now you at least have some preliminary data that are giving some insight of how we can preferentially stimulate these specific regions of the brain. So this is kind of the culmination of this story. I'll give you more, and you guys will tell me to shut up whenever. But all these tools on the left side of the screen are fair game, right? It all depends on the individual. Is it a novel and non-noxious stimuli that the individual will be able to accept? And then we're going to guide the experience with intent to be able to reconnect those 3 maps in particular. Okay, so that's kind of like how I want to position this moving forward. Oh, damn animations. I'm terrible with animations, so excuse me for that in advance. So let's start off with mechanical. So I think, Sean, when you initially posed, the answer or asked me to, focus on this, the why behind it, a lot of people think this should be the why, understanding what's happening mechanically to the tissues that we're interacting with. And most people want to talk about muscles, tendons, ligaments as movement therapists, but it's so much more than that. Just like I was just talking about, there's more maps that we should be considering. And so when it comes to the affecting the system mechanically, we need to understand that just like the nervous system is interconnected in a complex way, the tissues that we interact with from the outside in are interconnected in a complex way. And my handle on Instagram, which I somewhat regret now, is Fascia Doc. And I think it's too late now to change the term, because I think it somewhat pigeonholes me into thinking that I think fascia is the only thing that we're working with. It's one of many, but the fascial system is uniquely interesting here because it is the glue that connects multiple dense layers together, right? So we have the skin, the epidermis and dermis, we have the superficial fascia, the deep fascia, we have whatever organ it's encapsulating, either muscular, neural, intestinal organ, whatever. The system is layered, multi-layered, but multi-connected via what some would call fibrous septum. I'll just leave it at that. Most people are going to call it this fibrous linkage between different layers of tissue. So this is the kind of the imagery that I show my patients, because I want them, just like I want them to know that I'm going to be refining different maps in their brain, I want them to know why I'm sucking on a tissue to create decompression versus pressing on tissue versus gliding on tissue. Because what I've assessed with them is that the layers of tissue, just like I showed you in the previous slide, just aren't moving the way that they should, which could be leading to a threat response. So like pieces of paper on top of each other, they should be able to slide and glide. And if they don't, I want to find out why. And so what we're learning is that we're not breaking up tissue. So I think most of you guys know this, and there's been lots of conversation, but Robert Schleip is one of the leaders in this fascial science community. And he's really debunked the idea that we're releasing fascia or we're plastically deforming this dense connective tissue, or loose and dense connective tissue. Because if we were, it would take up to 2,000 pounds of force to create a deformation of this fascial network that I'm referring to. So it's unlikely that we can do so. What we're learning is that these layers of tissue, from skin to muscle and everything in between, should be able to slide and glide. So this should be an indicator that we look at. And Langevin, at least according to my literature review, was the first to kind of demonstrate this idea that there might be an association between how tissues slide and glide to symptoms or to movement. And so what we generally think of when there's a lack of mobility of tissue, any tissue, we usually say it's fibrotic. There's some type of scar tissue, which may be true later on, but most deficiencies in mobility or lack of glide of tissue are not fibrotic. They're actually densified. And the term densification is a term that you all should be aware of. And really it's based basically on the mechanical properties of fascia without altering the general structure, meaning the collagen laydown has not matured to a point where it's now altered the nature of the tissue. It's the density of the tissue that has been changed, and we can alter the density. So let me just show you what I'm talking about. Just showing you the different layers of tissue. I won't ask the question, it's all across the board here. So some of you have good experience looking at ultrasound, some of you do not. So I'm just going to show you the different layers here. We have the skin, the superficial fascia, the deep fascia, and then the muscle, at least in this case here. So these are the layers of the sandwich that you just saw there in the diagram. So now I'm going to show you in real time what this looks like in movement. So on the left side of the screen, just like it says in text, it says no low back pain. Look at the layers of tissue again: skin, superficial fascia, deep fascia, and then there's another layer of superficial fascia, but you could see how those layers of tissue are able to slide and glide. Those pieces of paper are able to articulate amongst each other. Look at what happens in the back pain. These are chronic back pain patients. The movement is a flexion distraction table, so they're laying prone on a table. The ultrasound head is applied on the parasagittal line, so just adjacent to the spinous processes in the thoracolumbar area. So that's what you're seeing in a topographical map. And so what you're seeing is that the layers aren't able to slide and glide. She was really the first to kind of identify that there was a relationship between the layers of those tissues able to move and symptoms that are experienced. So I thought this to be very interesting. And we're talking about this is 2015, I believe, that this study was done. I can reference it back. 2011, excuse me. And so this one really started to get us to start thinking about these layers of tissue that you're seeing right here, the superficial fascia, deep fascia, and the skin, and how we can influence it using different tools, different methods of interaction with the tissue. So you can actually do some really cool things with MSK ultrasound. The one I have is a wireless one. So it's literally nimble. I can move it around, don't worry about any cables. These are what I got these images from. And it is basically showing you that I can measure the amount of space acquisition that's acquired using something as simple as a cup on the body. So this is just showing you the cup would be applied to the skin. Then I'm manipulating the cup on the body. So once the cup's on the body, I'm actually twisting it, pulling it, sliding it side to side, and you can see what that's doing to the layers underneath the tissue. You can see how I'm articulating the different layers of tissue from each other to be able to create a change in some type of mechanic. And we're going to communicate what that change is. You can see the amount of space acquisition. Over here is where the sound head is on the just adjacent to the pod. And as I move it over the pod, so I would remove the pod and now see what happened. You're seeing a significant space acquisition. In this case, I saw more than 3 millimeters of change between those layers of tissue. So an appreciable change. Look what vibration does. I'm sure a lot of you guys are getting into percussion. We've created our own, vibration tool that does not create an amplitude. It literally shakes the tissue at different frequencies, which allows us to take one factor of the manual stimulus out of the equation. So vibration and percussion, or vibration and amplitude, we don't necessarily know which one is creating the effect. So what we did is we created a device that shakes, and we can measure the frequency of the shake, so to speak. So this is at 20 to 30 hertz. I wanted to bring it to your attention because I want you to see, look at the effect that happened to the superficial fascial line within seconds. I'll go back. So here's the start, right? Look at the organization, the wave-like pattern of the fascia. And as I continue on, the line starts to organize itself and starts to change its orientation. We can alter fascial tone, and we're starting at Schleip's work that's really providing this, that the receptors that we stimulate in this connective tissue layer can start to alter the tone of the tissue, because we do know that there are myofibroblasts, contractile units within the fascial system itself. So I'm presenting an argument here that maybe when it comes to the superficial fascia, 20 to 30 hertz might be more appropriate. Why do I say that? Well, I go to 30 to 40 hertz, I changed the frequency now. Now I'm not seeing much change to the superficial fascial layer. It might be hard for you guys to see on the screens that you're working from, but I'm using my mouse to show you this separation between the deep fascial layer. Deep fascia is typically 2 or 3 layers of dense connective tissue. And this is over the rectus femoris, by the way. And so it's right over the top of the thigh. And so what you're seeing at 20 to 30 hertz, which you don't see, at 30 to 40 hertz, that you don't see at 20 hertz, is actually a change in the space between the deep fascial layers. So maybe there's some insight here that we can gain from technology like this, that we can get in real time, that might change the frequencies of stimuli that we're providing, right? So I'm again focusing on mechanical. The 40 to 50 really starts to extend that change on that deep fascial line. If I could blow this up and measure this, that would be an appreciable distance that could be measured. And you can measure these with great measurement tools on most MSK devices. And then one more, I found this one to be really interesting, and that's why we call our tool the Rock Wave, is at 50 to 60 hertz, we get this consistent wave-like pattern that you don't get with other frequencies. What does it mean? I have no friggin' idea. So being honest is also is being truthful in the idea that there may be some therapeutic benefit of having something that creates a wave-like pattern, especially when it comes to fluid dynamics. But we just don't know yet, but at least we're capturing this type of information. So this is showing you again what's happening underneath the skin. Any questions on mechanics before I go to fluid?
Yeah, can I ask you a question on that? I don't
Sure.
want to steal your thunder. I'm not sure if you're going to get into it, but is the theory that for some reason the fascia densified, this could be due to some kind of painful stimulus that they're trying to avoid, so fascia densifies or whatever, and then the vibration of it is changing how it's laying down to some extent. Is that then going to help reduce the threat level that the brain is experiencing? And or I guess even a step before that is changing the way that it perceives the tissue, which then might change the threat level?
All of the above, Sean. I just love the question, and I like the thought process is this is what they're starting to capture, and you'll see you did step ahead, and I appreciate you doing so, that at least you're thinking that way, that by creating a stimulus, and I'm focusing on mechanical, now we're getting the fluid. These are things that we should just know. The other layers that I talked about in the introduction are just what adds more intent around these types of interventions, but these interventions are meaningful because slide and glide is dependent on fluid. But let's kind of show you those two pucks, laying on top of each other. If they can't slide and glide, what do you think your proprioceptive map information is going to be like? If the tissues don't have the ability to slide and glide in an area that should be able to slide and glide, is that information going to be aberrant that's going to be delivered to the brain? And the answer should be resoundingly yes. My proprioceptive map is going to be compromised because these layers of tissue don't have the ability to slide and provide the brain information of what's happening through movement, through time. So that is going to be the proprioceptive component that you referred to at the end. Nociceptively, yes, if the tissues are, I call it Velcro to my patients. I said, if you're in a Velcro position, you're going to be aberrantly stimulating these receptors, these nociceptors that are going to provide more danger signals to the brain, increasing threat, increasing pain perception, right? And I use danger signals purposefully. They're not pain fibers, they're danger fibers. They're providing information that the brain interprets to be able to make a decision. So yes, the slide and glide, if not able to, alters the map information through the receptors that exist in that local region of the body. So fluid-wise, we can influence the fluid dynamics by changing the viscosity of this fluid network. And if you haven't heard of the term hyaluronin or hyaluronic acid, dive deep into the research, because this is where the evidence is going on how do we improve mobility of tissue. It's through this fluid network that exists in all those layers that I just showed you earlier, in particular between the deep fascial layer and the target organ, in this case, the muscle. So the amount and quality of that fluid layer is critically important for the ability for the lubrication of the tissues. So if we have poor hyaluronic quantity in that fluid network, then it becomes more sticky, more like honey. So the viscosity is compromised. And so what communities like Menon and Antonio Stecco was involved in this study as well. You might recognize the name of the Stecco manipulation technique, is that they found that using this technique called T1Q mapping, it's a form of MRI imaging, they're able to actually identify the amount of hyaluron in the fluid around compromised tissue. So this is pre-treatment. This is of the forearm, and you can see the red would indicate something that's called unbound water. What unbound water really just means is that it's lacking in hyaluron or hyaluronic acid. Hyaluron is the lubricant, remember, right? It's what attracts water. It has multiple other proteins and glycans, like other constituents that make it really slippery. And the red is indicating that it's really lacking in that. And what they found through manual manipulation, and this is going to answer what you're asking, Sean, is that what this group has found is that there are 4 things that have been shown to be very effective in improving the hyaluronic quality, the viscosity of the fluid around tissue. And it really revolves around these 4 things: compression, stretch. When I say stretch, I don't mean stretch of tissue in particular, stretch of the tissue in a lateral vector. So moving the tissue, starting with the skin, in multiple different directions. Movement, obviously, and then all of these can actually increase temperature, which all of them in combination is like the secret formula to improve the viscosity of the fluid around tissue, to improve slide and glide. We improve slide and glide, we improve our proprioceptive map right off the bat. We decrease our emotional map associated with the nociceptive barrage. That's the affective component. And then, and just through all of these movements, compression, stretch, movement, we start to improve our exteroceptive maps. So you can see how I'm tying in those other things I talked about, because all of these have an influence on all of those components. One other thing to think about when it comes to fluid dynamics, there's two things that, according to, this is a modeling study. So this is taking tissues, putting it into, for a lack of a better term, a petri dish, and then exposing it to different stimuli. And what they found was, interesting enough, is that vibration at 60 hertz. If I went back, if I didn't have so many damn animations, I would go so. But if you remember, 50 to 60 hertz created that wave effect. Maybe there's a relationship here, is that the vibration at a specific frequency. They looked at other vibration frequencies and they didn't see a spike like they did in this bar graph here, combined with tangential shearing. So shearing is that lateral shear stretch that I just talked about. Those two combined could be potentially more effective in improving fluid dynamics. And they use this in this paper, they use this term called the squeeze film theory. If you guys aren't familiar with this, it's basically, if any of you have hydroplaned on a road driving your vehicle, you've experienced the squeeze film theory, where the front of the tire on a wet road starts to accumulate volume of fluid. And once they hit that critical mass of volume, now the wheel is no longer in contact with the road, so now it's floating. So the same thing is true. This is their description of this squeeze film theory as it relates to tangential shear and vibration. I could put these tools as if this is the tool itself. So this is my thumb. I don't know why I'm doing that with myself on the screen, but it's a thumb. It could be the tool head. It could be the floss fan, but it's, that front leading edge, just like it's showing here, this is pushing the fluid in this direction, is leading to this fluid quantity on the front edge of whatever implement that I'm using. So I'm going to show you the example through an image where, oh gosh, this is showing the wave effect again. So wave effect at 50 to 60 hertz. Look at the wave of the tissues that's happening underneath the skin. I'm thinking the same thing could be true using my mouse as the example. The head here is the front edge of the wheel. So I'm leading to a fluid dynamic, swelling here. And then I'm going to be gliding the head in a tangential way across the tissue to combine those two manual, components of the therapy. So let's say someone's having sticky hamstrings, they can't touch their toes. And so we're going to be working from their calf through their hamstring area with the goal of improving fluid dynamics by taking advantage of tangential shearing and vibration at a specific frequency. See where I'm getting at? I didn't choose 20 hertz because the evidence is saying you might want to lean towards a higher frequency. They call this the upper end of the flutter range. So the point is that knowing the why can make you more effective in the how by understanding what you're trying to achieve. So I'll stop there on fluid. Any questions on fluid? Okay, it's 8:48 my time. That's Central Time. Can you guys give me 12 more minutes?
Yeah, man, all yours.
Okay, good. Because we're this deep into it, and might as well just continue. So, and I might not even get done. I apologize, but I suck at quantifying time. So this is the part that is going to kind of add to the discussion that we talked about of what's happening sensory-wise. You guys know this probably better than I do. It's important to know that we're interacting with multiple different types of receptors in the tissues that we have access to, which is ultimately the skin, right? So we should be using the skin more deliberately. And this is coming from Diane Jacobs, hates chiropractors, by the way, but we speak the same language, in my opinion. She's a PT from Canada. I'm Canadian. I thought I had an in with her. It has not worked out, but she says certain things that really make sense to me. And really, it's the truth. It's the only tissue that is easily accessible. It's deformable. It has high innervation rates. It's loaded, meaning that it is connected to tissues below it, so it's interconnected, and it has a great way, basically a super highway to the brain, to be able to communicate to those different centers of the brain. So, and we know that the skin and fascial network, the network just below the skin, are 10 times more receptively rich than the muscular counterpart. So we're always thinking about muscle spindles, Golgi tendon apparatus, even joint mechanoreceptors. We know now that there's 10 times more sensory receptors to feed communication to the brain through the skin and fascia. So why not take advantage of something that's more superficial? It doesn't require me to drive an elbow into them. I could be less aggressive and still be as effective. So I want you to start considering other receptors, Ruffini's, Paciniae, and I highlighted in red for a reason, are these free nerve endings or C-tactile fibers. So ultimately what I'm saying here is that we're talking to the brain. We're trying to refine these maps that we talked about earlier. And the area of the brain that we generally go to is refining the somatosensory map. And this is demonstrating what Penfield identified through the homunculus that you guys have probably already studied, is that Penfield, well over 80 or 90 years ago, was able to map different regions of the body. This is the exteroceptive map, the homunculus. If your homuncular map is unclear, your threat is going to go up. So the goal is to refine the map clarity to improve our capacity to predict the future. But there are other ways of communicating to the brain, and we're starting to get some more evidence to support this. We could preferentially attempt to stimulate specific receptors called Merkels and Paciniae. Some of these are fast adapting, some of them are slow adapting, but I want you to think about these ones because these ones are clinically relevant, meaning that they can actually start to prime the nervous system for movement, start to improve our capacity to move. And the example here is what you're seeing here on the screen, or the top left would be what swimmers do before they get into the water. A lot of them do anyways. You'll see them splash water on themselves. You'll see them slapping their body parts that they're going to start to use. You see this all the time. You start seeing Michael Phelps with multiple cut marks all over his back, all over the target muscles that he's using when he's swimming. Why did he do that? Well, what we're learning from historical reference from people that were cupping him, they weren't cupping him for pain. They were cupping him to improve fluid dynamics, which we just talked about, to improve slide and glide, but also to bring attention to the area, to prime the nervous system to get ready to move. So I want you to think about that, is that we could preferentially stimulate these receptors, and they do respond to different dosages, right? The Merkels respond to like 0.4, which is super slow in respect to manual touch. Usually the average is within 30 to 60 hertz. 60 hertz is something that we could do with our hand, right? So we can stimulate the Merkel discs within an 18 to, let's say, 60 to 80 beats per minute, which is all doable by hand. As we start getting into the 300 hertz, like the upper end, then we're talking about ranges that we can't do manually with our hands. So maybe we take advantage of a device that can provide a frequency that's more consistent with those receptors. So again, the why, understanding what you're trying to achieve. I have someone that is hypotonic. We're seeing some poor connection to their body. Their map is compromised. I want to interact with their system and their tone of their tissue by stimulating these receptors that talk to that part of the brain to be able to upregulate the nervous system, get it ready to move in a more effective and efficient manner. The opposite is true. I really got to get rid of these damn animations. The opposite is true when it comes to down regulating. What we're learning is that if we take advantage of the Ruffini endings, which are generally a little bit deeper in the tissues, we can create a relaxation response. Ruffini endings create a global relaxation response. They create a parasympathetic stimulus. So they help to kind of bring the system that's in high tone, high threat potentially. So we start thinking about, maybe I want to take advantage of Ruffini's to bring the tone and the quote unquote, the energy down. So what we're learning here, even from what we're able to capture in real time, look at This is a deep, slow stimulus, which you're going to see in the next slide, is the preferential stimulus to be able to stimulate Ruffini's. Look what's happening to the fascial layer here. You're going to see a significant offloading that happens right there. So this is what, 10 seconds in, we're talking about a true change that's happening into this fascial network that I can replicate. I don't get this when I go fast. I don't see this offloading expansion of tissue. I see more shaking of the tissue, but I'm not seeing this type of true relaxation response. And this is what I want you to demonstrate here a couple of times so you guys could see that last little bit there was significant. So maybe we can down-regulate the tissue by stimulating it with a deep, slow stimulus. Did someone jump off? Is there a question? Okay, so I'm almost done on this section, and then we'll stop again. So ultimately, I think we can become more precise in the tools that we use and how we use them. So some we might want to go superficial and light to be able to stimulate more of those superficial fibers that communicate to a specific map system that helps to prepare for movement. We can go slow and deep to stimulate Ruffini's to create a relaxation response when we see a lot of hypertonicity and tone. So it just gives you some insight on dosages that I can titrate according to what I'm trying to achieve. All of them are to kind of improve the sensory maps once again. I see that shaking one more time, I'm going to explode. This is the one that if I didn't give you this, I would have left you incomplete. Understanding neural anatomy, which I didn't even care about when I was sitting in a classroom that a lot of you guys are unfortunately sitting in and not really putting into application. Understanding that this S2 region of the brain, which we're just starting to get better clarity of what its actual function is highly involved with recognition and memory, not just what the primary somatosensory cortex is on localization. Where's my shoulder? Where's my elbow? Where's my wrist? The S2 region is involved with localization, but more so of remembering the location of that in relationship to a specific experience. Why do I think this is important? If I go back to what I showed you earlier, all these centers are interacting with each other. The S2 is closer to the thalamus and closer to the insula for a reason, because it has a conversation with these two that requires more speed of transmission, more reactivity, if I could use that term again, taking information of recognition and memory that can actually feed the affective and motivational experience that I'm having, along with the input that I'm getting from the body. So I'm going to come back to this in a second, is that this S2 region can be stimulated, but it also can have an effect on the insula. So the insula is really important, and it's actually preferentially stimulated by receptors in the skin, specifically hairy skin, most of our body, not the glabrous parts of our skin, our hands and our palms of our hands and feet, is that we're talking about these C tactile fibers. And when you stimulate these fibers in a specific way, we actually preferentially stimulate, obviously the thalamus is the relay station, but the insula. And the insula is critically important when it comes to the anticipation and perception of pain, the sense of well-being, getting a sense internally, what well-being, what does it feel like when you just feel at ease? And you've all had that. Sometimes it's medicated, where we have that ease when we have a drink or two, or other things. You know, people get into this sense of ease or well-being. That's why alcohol and drugs are rampant, is that it stimulates specific well-being centers of the brain, including the insula, to be able to create that sense artificially, unfortunately. But this is an important part of the brain, because if the mapping of this part of the brain is compromised, the inner map, we're going to have problems. So our goal is to make the precision of the information that is fed to the insula better. I'm going to skip the chemical section because I want to show you how I put it all together. But chemically, just understand touch affects oxytocin release. It has an effect on mTOR, so it actually improves the repair of tissue. So you just need to know that there are ways of influencing chemical mediators that actually influence healing rates, oxytocin being a robust nature of pain perception. So I'm going to skip to that and just go to this so I can just finish off this last section and show you how I put it into action. So the reframed approach, taking what I just provided you, and I obviously skipped over a whole bunch, and I didn't go into detail enough, but really what I'm going to talk about this is that we can start the process of diffusing threat being the goal here is to mitigate threat any way that we can. And we're going to do so by connecting to the body, connecting to the brain and the mind, and then connecting to meaningful movement. So these are the 4 components of the stack that I now integrate into all of my treatments. And I do so because I'm getting better outcomes than I did even 6 weeks ago. So this is something that I've learned over 20 years of experience, but now the evidence has started to support this, that we're going to first do something that I call painting the area. I want to remap the outer part of the body. So I'm going to use whatever tool I have, from my hands to vibration, to cupping, to instrument assisted techniques, to flossing. You can throw in whatever tool you want here. But the goal here is to start bringing attention to an area that's lacking in exteroception. That's step number 1. Really start to connect with the body part. There's lots of cool exposure ways that you can change the exposure. I could do it from superficial to deep. I could do it from a short position to a lengthened position. I can go above and below. So multiple ways that we teach within the curriculum that I develop, but it's just to kind of let you know that it's not just a cookie cutter, just, paint an area and then you've got the exteroceptive, map clarified. It's more robust than that. The second part is really starting to refine the interoceptive map. And this is where curiosity comes in. So what you're doing here is you're really starting to challenge what they're feeling inside and challenging what it means, the narrative that we usually give ourselves. So chronic pain sufferers and even someone that rolls their ankle and they're an elite, athlete, the immediate narrative that people start to, deliver, especially when they don't have good information, is that they start to say, this is going to be the end of my career. I won't be able to play with my kids any longer. So the narratives start to feed the experience. We can change that by doing something that's called reappraisal. Through curiosity, you're asking someone just to sense what's happening inside, but not add a layer of judgment on top of it. And this is not just an opinion. This is coming from communities like Cynthia Price, which if there's a paper that really will give you some guidance on how to apply this layered approach, the somatic reappraisal approach is a great objective way of applying this in a real setting. So, and she talks about this idea of how emotions are embodied, how we feel sadness, how we feel anxiousness. All of you have experienced it. Some of us feel it in our hearts. Some of us feel anxiousness in our heads. We get, flushed. So the experience is real. What she's doing is she's now asking people to expose what they're feeling verbally through a curious lens. And the pain reprocessing therapy is another community, another research group that has demonstrated significant improvements in chronic back pain by having people rethink how they feel when it comes to the experience within. And so all I'm asking you is to start to consider this idea of productive attention, starting to apply a selective stimulation. It needs to be non-noxious, mind you. So dropping an elbow in someone's back just because you think you're moving some tissue isn't gonna work with this threat model of thinking. So it needs to be non-noxious. It needs to be novel. So it needs to get the attention of the brain. So that's why I like using vibration. And then you're adding this layer of productive attention, asking them to say, what are they feeling? And you might ask, what things are you going to ask them to deliver? You're basically guiding them. So it's a guided exploration. So I'm asking them to tell me what pictures that they're seeing in their mind when they close their eyes and dive under their skin and start to feel what they're feeling inside. And you'll get a lot of information. This is just telling you, I'm not going to get into this because it's going to take me an hour to explain this, but there is a process of reappraisal of information from the back of the insula to the front. And if you want me to go in depth on this, we can set up another session. I'll be talking about this at the RTP conference in next year. I've been asked to speak, and I'll be talking a lot about this and putting this into action. But through light touch and slow rate, 3 to 10 centimeters per second, we can stimulate these C-tactile fibers that feed the insula. And while we're doing that, we're asking them to tell us what they're feeling inside. Is it warm? Is it cool? Is it a subtle sensation or an abrupt sensation? Does it give them ease or dis-ease? You know, like we want them to just experience what they're feeling inside. And so that's the second part of the stack. The next two are pretty easy. Gosh, I can't believe I showed all these. This is just showing you how I would do it on a specific area of the body. I'm having them tell me which direction I'm going. So in this case, I'd be going counterclockwise. So exteroceptive map clarity. Then I might start drawing some tic-tac-toes on them and then asking them to tell me what quadrant I'm in. And then I might say, is the vibration fast or slow? Is it dull or sharp? Is it warm or cold? So now I'm starting to dive in and asking questions about what they're feeling inside. We start gamifying it, meaning saying, okay, tell me, draw on a piece of paper that they would have in front of them, which quadrants did I just move into? So now I'm asking them to go through stereography, meaning that they have to draw the pattern with their extremities to be able to kind of tie the knot between those areas of the body. A couple of areas that you should, or a couple of communities you should look into is the body psychotherapy resource, the United States Association for Body Psychotherapy, great resource to kind of talk about how we layer in curiosity or reappraisal tactics with manual therapy. The Psychophysiological Disorders Association, another great community that has done a lot of research on how to change the narratives around pain. Curable app, if any of you guys, I don't know if it's on Android platforms, but I know it's on iOS. This is a great, someone, I think it was Lucas, was asking, how do I extend this outside of the office? This is an app that would actually give people guided visualization meditation practices that do while they're moving. So it actually feeds them along the path. So that's another great homework tactic. I incorporate breath into the stack. So breath has been demonstrated to actually connect to specific interoceptive maps of the body. It's been shown to diffuse pain just by changing the rate of our breathing. It's a mood reprocessor. So if you're feeling anxious, we can actually change anxiousness to ease by just changing your rate and duration of your breath. In particular, the type of breath that's been shown to be most effective in changing tone of the nervous system is something that's called the physiological sigh. I'm a big Andrew Huberman fan. He's been talking about this for about a year now. And if you listen to his podcast talking about the physiological or the intentional sigh, there's lots of good research talking about breathing in this fashion, where you breathe in normally 3 seconds, take a quick sniff in, inhalation, you volumize the alveoli of the end of the bronchial tree, and then you extend your exhale by 7 seconds, has been shown to make significant changes, HRV changes. All autonomic indicators are modified by changing your breath into this style. So what I've been doing is I've been integrating the intentional or physiological sigh while I'm painting an area, while I'm asking them to be curious. And then lastly is exploring. So the part that I'm going to end off with tonight is saying that meaningful movement is the goal. So if you can now ask the individual to move while you're layering the other 3 components that I just talked about in a meaningful way. This is as an example, someone that was having pain in this pose in yoga, which is a meaningful community, a meaningful movement that she wanted to get back to. if we can demonstrate that we can mitigate the pain, mitigate the threat associated with that movement, we've opened up the Pandora's box of opportunity, right? So we change the narrative. So that's the last part, is having them explore meaningful movement again, which is what brought them into your office to begin with. So I'll stop there. I know I said a lot. I talk a lot. I do so purposefully because I truly believe in the message that I'm sharing on the screen right now, is that the more you feel, the better you move. The better you move, the more you feel. If we can improve the feeling maps of our extero, intero, and proprioceptive, regions of our brain, I know that you'll move better. We teach these concepts in all of our education. I create all of the education, and I layer these concepts into each of the tactics that we teach within the platform that I have. If you guys, I'm just starting it this week, so if any of you guys have interest in following me, it's Fascia Doc, as I said earlier. You can take a shot of that QR code. It'll take you to my Instagram page. What I'm trying to do this starting this week is I'm going to do a weekly post. It'll be a weekly post on research and how it applies to something that I believe in. Taping tactics that are consistent with what the literature is indicating for pain and movement. Tooling tactics, what tools that we have access to and how we can better utilize them. And then some type of movement tactics. So there'll be 4 weeks of some type of post on a weekly basis. And then on the 5th week, I'll do an interview with someone that I think is practicing in this fashion to show people that there are people using this type of reappraisal model, this predictive embodiment model, to be able to help people move and feel better. So that's something for you guys to take advantage of. My email is steve@rocktape.com, pretty easy. If you have any questions, please feel free to reach out to me. I'll send this slide deck notes to Sean, and Sean, you could dispense it to whomever. And I'll take any questions now.
Dude, that was gold. I asked for the why and you hammered home. One question I have is, I think a lot of questions right now around what we do and what people expect when they come in to see us is changing, especially like that continuum that you showed was awesome, because there's been a lot of talks about like pain splaining, like trying not to just be a therapist and talk people out of their pain, because that doesn't work, but also you can't just move bones back into place. There's somewhere in the middle, right? When someone comes in and you are using these kind of vibration tools or your hands or whatever, but you're trying to move away from just being like a massage therapist, essentially, how do you explain to the patient what you're doing, and how in depth do you go in terms of brain remapping and stuff, or also just like gamifying? Like, where does that line get drawn?
Yeah, it's a good question. I probably don't have like a blanket answer that applies to everyone, because as you all know, and as you will learn, there's no such thing. But what I would always suggest is you're capturing information. So screen, rescreen. Greg Cook always said it best. If you're not screening, you're guessing. And so that to me, it's really important to understand that you're screening these maps, of which you can. And I can extend. This is a short form of a 6-hour lecture that I deliver on this concept. And we go through the screening process of 2-point discrimination, the Maya screen, which is the multidimensional assessment of interoceptive awareness. I can't believe I remember that. So multidimensional assessment of interoceptive awareness. It's a open source 37 question screen that you can kind of get a sense of what someone's clarity of their interoceptive maps are. But my point is that once I capture all the information, their movement map, classic movement screening, I'm an FMS guy. Interoceptive map, I use Maya. I use heart rate detection, which is a interoceptive sensitivity. You guys just sitting there, can you guys, without me jabbering in your ear, can you guys sense your own heartbeat, and are you accurate in measuring your own heartbeat without taking your pulse, without using a device? Can you just sense it? That's an interoceptive sensitivity or accuracy. So you can measure that, and you can change that according to the curiosity muscle that I'm suggesting that we work on as we're doing the treatment. So I have all this information and I whiteboard it just like I would if you were my patient. I'm going to be explaining as I'm manipulating. I'm going to be using a vibration tool. Hey, you remember that exteroceptive map, or that, I don't call it the exterocept, that outer map? You don't know where your shoulder is. I'm going to be doing this, and we're going to check right afterwards, and I'm going to demonstrate to you that I can make it more clear to you within one sitting. And so it kind of builds confidence that they understand what I'm trying to achieve each and every session. And as I screen each and every treatment, we start to identify that the outer map is clarified now. We're going to be focusing attention on the interoceptive and proprio. And eventually they're set up in a place to know when they feel that their maps are being smudged or their symptoms start to increase, I believe it was Lucas, what are the tools that I can throw in for their home care and use something like Curable that I can extend the treatment outside of my office. So that's how I would answer that question, is that you got to start somewhere, and you start by understanding where they are through screening and assessment. And then I start to slowly progress towards a movement model, meaning movement is your tool.
Awesome. One side question, then I'll shut up so anyone else can ask. Are you using these tools as well during movement to like continue the proprioceptive game?
For sure. Yeah. So what you'll see in this latest course that I developed is that none of these tools should be done in isolation. They should be done, stacked together, and you could slowly start to add layers to it. Because if someone isn't in the stage of recovery where they should be moving, so we're gonna move for them. So we could use the tool as the movement, and then we start getting some passive movement where I assist them, and eventually it'll be active assisted, and then active, and then active resisted. So multiple ways that I can titrate the experience dosage, if you will. But yes, the goal is always to do these with some type of movement. What else you guys got? I'll take that as an answer. Hopefully that's not a bad thing. So I understand I talked a lot, and I hope it just kind of reframes, using the term that I started off with, just giving you a different lens to look at things. You might not believe what I'm saying yet because you haven't seen it in action. That's what I want to demonstrate at the symposium this coming year. I think it's going to be up in Dallas, up the street from me. So I'm excited to be part of that. I was able to host the first R2P conference at my facility in Denver. I sold that. Now I'm in Austin, but I'm all about your group. I want to support you guys as students. So just please take advantage of leaning on me if and when you need it. So you're never gonna, I'll never respond negatively. Let's start with that. So you can ask any question. You can ask as many as you like. I was that student, and I felt that I was able to lean on giants in the community that I still talk to now, 20 years in. So if you felt like any of this that I could be of assistance, please feel free to reach out, steve@rocktape.com. I'll give you my phone number if you wanted to communicate in that fashion once you guys reach out to me. So thanks for the opportunity, Sean and group.
Yes, it's awesome. Yeah, looking forward to see you. I know John's asking about symposium date. I think it'll be one of the weekends. Yeah, first weekend in February.
It's February. Bo just gave me a date. I hope I'm not talking in advance before it was actually exposed, but I got the weekend of the 4th of February.
First week.
So,
Tyler, no asking questions. Trying to get inside information. Cool. Yeah, this has been amazing, and we hope to do more things like this in the future. If anyone has any questions going forward, he's got his contact right there. In terms of for the next NSEM meeting, we'll do this again at the start of December. And the NSEM's gonna be talking with each other over the next week about the feedback that you gave us and things that you want us to do. So with that, I'll let everyone go to bed. Appreciate you all. Capo, especially appreciate you.
great. Thanks, guys.
I'll see you in February. See you guys.
All right. Bye-bye.